Hi guys, this is Professor Elliott. We're going to review Chapter 16, Psychotherapeutic Drugs. So we're going to discuss anxiolytic drugs, we'll discuss antidepressants, antipsychotics, and mood stabilizers today. And anxiolytic drugs specifically are drugs to decrease anxiety. We have two specific types of classes for this. We have benzodiazepines and then other classes. So we'll discuss benzodiazepines and buspirone. We discussed benzodiazepines last week. All of these drugs are going to decrease overactivity in the central nervous system. So that's going to kind of bring a sense of calmness and with that decrease anxiety. We remember benzodiazepines are PAMs and are LAMs, like alprazolam, diazepam, and lorazepam. We kind of utilize these differently. Lorazepam is pretty quick. We like that, especially for acute panic. Buspirone is a drug that we take consistently. I kind of think of it like an antidepressant's friend, just a little booster. So let's talk about these. Benzodiazepines overall increase GABA. GABA is a neurotransmitter that results in decreased stimulation in the central nervous system. So if we increase GABA, we decrease stimulation. These medications can be used as sedative hypnotics, anxiolytics, for seizures, skeletal muscle relaxants, or alcohol withdrawal. They are contraindicated in narrow angle glaucoma. Glaucoma is increased pressure in the eyeball. The narrow angle is the more serious one. These are also contraindicated in pregnancy. Our adverse effects are headache, drowsiness, falls in older adults. We're always concerned about that with drugs that make us drowsy. And then a paradoxical reaction. So if this medication makes us sedated, the paradoxical reaction would be the restlessness. This is a Schedule IV drug. Buspirone or Buspar has unknown activity, but it's thought to be an agonist with serotonin and dopamine. Serotonin increases a sense of well-being. Serotonin is also really indicated in helping anxiety. Buspirone is not taken PRN, which is as needed. I think a lot of people get that prescribed, almost like a little benzodiazepine you can take as needed. That is not how this drug is. It's dosed twice or 3 times daily. It's indicated just for overall anxiety. Now, this can cause a paradoxical reaction. It can cause dizziness and blurred vision. It's typically not super sedating, which is good, but it may cause serotonin syndrome, and we will talk about serotonin syndrome. Then we'll talk about our mood stabilizers. So the big mood stabilizer we need to talk about is lithium. The other mood stabilizers we talked about in the anti-epileptic chapter, these would be like carbamazepine, oxcarbazepine, Lamictal or lamotrigine. I don't really think we use gabapentin for that. And then divalproex, valproic acid, which is Depakote. So those are kind of the other ones you'll see. Lithium is just used for mood stabilizing properties. When we talk about bipolar, we think we have 2 poles. So think bi as 2 and then poles. So these are 2 mood poles. So we have this depression and then we have this mania. People think of it kind of like mood fluctuations. It's not mood fluctuations. Bipolar is a discrete period of depression, and that has to be for a few weeks or so. So this would be, it can be a pretty bad depression. It could be agitation and low mood. It can also be not getting out of bed all day, not eating, just think of it like darkness. So somebody who has major depressive disorder, that's part of bipolar. So we have that depression period. And that's not just a few days, it's a few weeks. These patients then, and it's not all the time, it can be just a few episodes, will have at least 1 episode of mania. Now, mania is the opposite end. It's the opposite pole. So mania is a period, typically 1 week. There's different kind of forms of bipolar, but bipolar 1, which is the more severe form, is 1 week of Elevated mood, elevated activity. People think, oh, these patients are, they feel like they're on top of the world. There's a lot of agitation that comes with it, and it's not all euphoria. These patients may have hallucinations, they may have delusions, so they have some kind of psychosis associated with it, and they may need to be hospitalized. So bipolar is a very serious illness. There's a high rate of suicide with bipolar. So when we think of highs and lows, it's not really that. You could just have one manic episode in your entire life and still be bipolar. So even though you're depressed most of the time, that one episode of mania characterizes bipolar. This means even though you're depressed most of the time, treating with antidepressants is ineffective. So these patients specifically need mood stabilizers. So they may be on the anti-epileptic drugs, but lithium is also something. Lithium has a narrow therapeutic index, which gives us kind of a lot of pause. Lithium is very effective. It is very effective in preventing against suicide. Suicide is the deadliest thing that can happen in the psych world, so that's a huge deal for us, especially since bipolar patients have a higher rate of suicide. So this is thought to work kind of with the sodium ion and the transport within the nerve cell to just stabilize it. We want not only the depression to alleviate, but also the mania to alleviate. So kind of meeting in the middle here. Lithium has quite a few side effects. The adverse effects and the toxicity really look similar. The adverse effects specifically kind of have this fine tremor. We can have this GI upset, and then also weight gain. So nobody likes weight gain as a side effect. There's some big interactions, and I'm really going to harp on these when we get to the cardiac section, but if somebody is on a thiazide-type diuretic, they should not be taking lithium. A thiazide-type diuretic is like hydrochlorothiazide, which is a really common blood pressure medication. So if a patient takes hydrochlorothiazide, because they have high blood pressure, which is a normal thing, and they're taking lithium, the hydrochlorothiazide or thiazide-type diuretic will not allow the lithium to be excreted. So we're going to get this build-up of lithium. Lithium toxicity can be fatal. So we see why that's a really big interaction. It's not just something, oh, they'll feel kind of funny. No, this could lead to death. Now, ACE inhibitors, so ACEI, so angiotensin converting enzyme inhibitor, which we'll talk about in 2 weeks. The ACE inhibitors are things like lisinopril, they're your pearls. They're also a blood pressure medication, very, very common. The same thing with the ACE inhibitors. If somebody's taking an ACE inhibitor like lisinopril, that lithium is unable to be excreted. We know if lithium is unable to be excreted, it's going to lead to toxicity. The same with NSAIDs like ibuprofen. Lithium's a pretty interesting drug because it's actually not metabolized. It's just excreted. So that means if something is going on with our kidneys, something is impairing that excretion level, it's just going to keep building up, right? It's not going to kind of break down. It's just going to keep building up. Lithium is actually a naturally occurring element in the periodic table, if you want to throw back to chemistry, which is pretty cool. So it occurs naturally in the world. So it's a mineral, right? Areas of the world that have higher amounts of lithium in their rainwater, their runoff water that gets into their water supply, actually have overall lower rates of suicide, which is really cool. So nobody's putting lithium in their water, but these areas of the world that have more lithium from that runoff water into their water supply have lower rates of suicide. And this has been shown throughout different continents. It's a pretty cool phenomenon. So I want you to know the lithium level. So your lithium level is 0.6 to 1.2. You want to monitor your lithium levels, and that's pretty frequently. You're also going to monitor your sodium levels. So 2 things about lithium toxicity we know we can't use: thiazide-type diuretics, ACE inhibitors, or NSAIDs. If a patient has a low sodium level or a dehydration, those can both lead to toxicity, okay? So I would know those things. I think lithium's kind of a hot topic to discuss on the NCLEX and the HESI. So I would just kind of wrap that little fact away. I call things like high yield versus low yield. So high yield, basically, if you know it, you're going to get more questions right than if you know kind of some benign fact. So this I would consider high yield.